The endocrine system does work a little bit slower than the nervous system. So the nervous system is very fast and it does release neurotransmitters like acetylcholine, epinephrine, norepinephrine. And the endocrine cells or glands will release hormones that will go to a target cell. So we have a gland that releases a hormone that goes to a target cell. Okay, so if we were to draw that out, here would be a cell with a receptor, and the hormone would bind to that receptor. And then once that binding takes place, then something will happen. Okay, and then we'll get into those somethings in a little bit on another lecture that has to do with each hormone and where it's coming from and where it's going and what it does, what that hormone does once it binds to the receptor. Okay, we also have steroid versus non-steroid hormones. Okay, so steroid hormones versus non-steroid hormones. Another way of saying non-steroid hormones would be peptide hormones. All right, so steroids are lipid soluble. The cells in our body have a lipid membrane. Okay, hopefully you got that from ANP1, where it's a phospholipid bilayer, and it's designed to protect the cell. Okay, those lipid bilayers are selectively permeable, which means it only allows certain things in and only certain things out. In this case, with a steroid hormone, because steroids are lipid soluble, so I'm going to designate a steroid hormone just simply with the S. So a gland released a steroid hormone, and in the middle of a cell you have the nucleus. And what happens is the steroid hormone can simply diffuse across the membrane because it's lipid soluble. So the steroid hormone can diffuse across the membrane and go directly to the nucleus. And once that steroid hormone binds to the nucleus, then something happens like protein synthesis. Okay, a non-steroid hormone requires a receptor. Okay, so we have the gland that releases a non-steroid hormone, also known as a peptide hormone, and that's going to then bind. So we have a cell, and the cell has a receptor. Okay, and so this particular non-steroid hormone will bind to the receptor, and what that does, it creates an activation of some mechanisms on the inside of the cell called second messengers. Okay, so the second messenger will continue to relay the information to influence the nucleus of the cell. Okay, but in order for this to work, you need a receptor. Okay, it's called an extracellular receptor. So we have intracellular, which means inside the cell, and we have extracellular, which means outside of the cell. And once there is binding of that second messenger, then there's some sort of product that is created. Right, the hypothalamus and pituitary gland is considered one of the most important endocrine structures in the brain and the human body. The pituitary gland begins to form around week 8, okay, in utero. And once you're born and you grow into your adult skeleton, forever you're going to have this anterior and posterior pituitary. Okay, the anterior pituitary is also known as the adenohypophysis. And the name anterior pituitary comes from when you're looking at a person from a lateral view. Okay, so here is a lateral view. So this would be the anterior aspect of the person. This would be the frontal lobe. And here's your occipital lobe. So this is the posterior aspect of the person. So simply by direction, the first structure that you come to is located anteriorly, and then behind it sits the other part of the pituitary gland. So that's where it gets anterior and posterior pituitary from. Okay, so you can see that here, anterior pituitary, also known as the adenohypophysis, and then there's the posterior pituitary, also known as the neurohypophysis. All right, what connects the hypothalamus area to the pituitary gland is the infundibulum. Okay, the infundibulum, also known as the pituitary stalk. All right, you'll notice that on this diagram there is hormones that the anterior pituitary releases and hormones the posterior pituitary releases. Okay, here's a bunch of the hormones that we're going to go over. So gonadotropin releasing hormone, thyrotropin releasing hormone, and so on. Okay, so there's a bunch here. And then you'll also notice that the posterior pituitary only releases 2 hormones, oxytocin and antidiuretic hormone. All right, and then the anterior releases everything else. So follicle stimulating hormone, luteinizing, prolactin growth hormone. Okay, here in a minute, we're going to do some flow charts on these hormones so that you know where they're coming from, where they're going, and what they do once they get there. All right, the reason why the posterior pituitary is also known as the neurohypophysis is because of the nerves that are connected to the posterior pituitary. And the anterior pituitary is more of a capillary portal system. And you'll notice all of these portal veins and capillaries. So as a result, it gets the name adenohypophysis. Okay, getting into the hormones, we're going to do a flow chart here. So, in other words, some longhand notes. So, grab paper and a pen, and let's get into it. All right, based on the book, the first one is the gonadotropin releasing hormone. Okay, so the hypothalamus is going to release gonadotropin releasing hormone. Okay, there are a lot of abbreviations in the endocrine system. Okay, so you'll have to know both the full name and the abbreviation. Okay, so gonadotropin releasing hormone. And the word gonad is in it. Gonadotropin releasing hormone. Okay, that goes to the anterior pituitary gland and causes it to release follicle stimulating hormone and luteinizing hormone. Okay, luteinizing hormone and then follicle stimulating hormone. Okay, now sometimes the answer is within the word itself. So follicle stimulating hormone, well, what do you think that's going to stimulate? Well, the answer would be follicles. Okay, if follicle stimulating hormone goes to the testes, now keep in mind these are gonadotropin releasing hormones, and the gonads in a male are testes, and the gonads in a female are ovaries. Okay, so when FSH goes to the testes, it will specifically go to the Sertoli cells. And those Sertoli cells are found in the testes, and it's going to help with spermatogenesis. Okay, spermatogenesis is the creation of sperm. Okay, if it goes to the ovaries, then it's going to help develop the follicle. Okay, a side note, a follicle is essentially a fluid-filled sac inside of the human body. Now, it doesn't always have to be fluid, but you'll often find that our follicles have some sort of fluid in it. And in this case, inside of the follicle is going to be an egg. Okay, also known as an oocyte. And with the female cycle, you have menses. Okay, and then once that's done, by day 14, there's ovulation, and that egg is released from the follicle. And if there's then no pregnancy, then by day 28, then there's menses. Okay, so we'll get into more of that down the road into more detail, but that's the quick version of, in this case, a follicle and what a follicle stimulating hormone will function in the human body. Okay, luteinizing hormone in a male goes to the testes, specifically the Leydig cells. And what they're responsible for is testosterone. And testosterone does have an influence on spermatogenesis. Okay, so in other words, low testosterone or no testosterone can decrease or inhibit spermatogenesis in a male. Okay, luteinizing hormone, if it goes to the ovaries in a female, then it's going to help with ovulation. Okay, the hypothalamus will release growth hormone, releasing hormone. Growth hormone, releasing hormone. Okay, so that will then go to the anterior pituitary to tell the anterior pituitary to release growth hormone. Okay, now make sure you know both the full name and the abbreviation. So GH there is growth hormone. And the answer is within the word growth hormone. Well, what's that going to do? Well, if it goes to tissue, like any tissue in the body, it's going to help with growth. And if it goes to muscle, then it will help increase in protein synthesis. And what that means is you're able to put on muscle. And if it goes to adipose tissue, which is a fancy way of saying fat. Okay, so our fat is adipose tissue. Then it increases in lipolysis. Okay, which is the breakdown of fat. Okay, growth hormone is released a lot during puberty and throughout the latter adolescent years and early adulthood. And then at some point it starts to naturally decline over time. If a person needs growth hormone, they do have it as a shot that you can give yourself. Some bodybuilders and performance enhancing people will use growth hormone. And that's one way you can start putting on massive size. Now, I'm not advocating do that. I'm just saying that we have it naturally in our body, and they also do have it as a form of a shot if a person needs it. Okay, another hormone, and we're still focusing on anterior pituitary here, is the hypothalamus is going to release thyroid releasing hormone, which goes to the anterior pituitary to release thyroid stimulating hormone. Okay, thyroid stimulating hormone. And where do you think this is going to go? Okay, the answer is within the statement, thyroid stimulating hormone. Well, it's going to go to the thyroid to stimulate it to release your thyroxine, which is also known as T4. And the target cell is virtually all cells in the body because it is responsible for metabolism. Okay, now a fancy way of saying metabolism is it increases your BMR, which stands for basal metabolic rate. And an easy way of looking at your BMR, which, by the way, you're also going to contrast that with total metabolic rate. I'll talk about that in a second. So if you were asleep, how many calories are you burning? What is your metabolism when you are asleep? Okay, that's just an easy way of looking at this. So when you're sleeping, your heart is still beating, you're breathing, your cells are still functioning inside of your body, you're still releasing neurotransmitters, your brain is still active, your blood is circulating, your immune system is working, you're doing growth and repair stuff. Your body, if you ate dinner before you went to bed, which is fairly common, your body is working on breaking down the food. So all that digestive stuff. So how many calories are you burning when asleep, okay, or not moving? That's basal metabolic rate. And that's your metabolism, okay? And thyroid hormone is responsible for that. Now, some of that's genetic. Some of that's also how active you are versus how sedentary you are, okay? Now, TMR, which is total metabolic rate, is you also include your activities for the day. So if you're training for a marathon, then you're doing all that running. If you're a triathlete, if you're a swimmer, if you lift weights, if you just like walking around the block in the neighborhood, or someone who just sits all the time at a computer, sits at home, watches Netflix and all that, as you can imagine, there's going to be two different total metabolic rates. The more active you are, the more calories you're burning. The more inactive you are, the less calories you're burning. So that's a person's total metabolic rate. And that does eventually have an influence on the health of a person's thyroid. Now, there are many issues that contribute to a person's thyroid health: diet, lifestyle, autoimmune. That's quite a long list that can hurt the thyroid. But one of them is, are you helping the thyroid by being active, or are you kind of hurting the thyroid by being inactive? Okay, the other thing it does is it helps increase protein synthesis. Okay, another hormone. So we have the hypothalamus that releases prolactin, releasing hormone, or PRH. And then that goes to the anterior pituitary gland. Okay, so going back to that diagram, remember we had the hypothalamus, the infundibulum, also known as the pituitary stalk, and then the anterior pituitary. So this is how they communicate. Okay, so the hypothalamus was up here in the brain, and then there was the pituitary stalk, and then you had that front part, which was the anterior pituitary, and then you had the back part, which is the posterior pituitary. Okay, so that hypothalamus communicates to that anterior pituitary. All right, since it's prolactin releasing hormone, then what do you think the anterior pituitary is going to release? Well, the answer would be prolactin. And this would go to the mammary glands, which are in the breasts of a female. And they are typically activated because of pregnancy. Okay, it's unusual to have prolactin do its job if there's no pregnancy involved. So pregnancy happens, 9 months, deliver baby, and then breastfeeding time. Okay, so that is what prolactin does. And it helps with the synthesis of milk. Okay, the hypothalamus releases corticotropic releasing hormone. Okay, the hypothalamus releases corticotropic releasing hormone, which communicates to the anterior pituitary gland, which then releases adrenocorticotropic hormone. Okay, adrenocorticotropic hormone, or ACTH, and make sure you know both, the abbreviation and the full word. Adrenocorticotropic hormone, and that is going to communicate to the adrenal cortex to release cortisol. Okay, if cortisol goes to the liver, then it's going to help with an increase in glucose synthesis. Okay, side note on this, when you're stressed, cortisol is released. And it takes a lot of energy to go through that stressful situation, so you need glucose. Glucose is one of our energy sources. Okay, it goes deeper than that, but for time purposes for now, we're just going to stick with this. Another thing cortisol does is it's an anti-inflammatory. Okay, anti-inflammatory. Now, there's a medication version of this, cortisone. So you might have heard of people getting cortisone shots. And if you do, the purpose of the cortisone shot is to decrease inflammation, which would therefore decrease pain in that area where you got the shot. Now, a trade-off is it also decreases your immune system. All right, so it's immune suppressant. So the longer you're in stress, the more immune suppressant you become and more susceptible to illness. So if you pay attention to people out there, and this may include you, if there's been prolonged stress, especially, pretty serious levels of stress, toward the end of it, you'll notice at some point the person just gets sick. Okay. If cortisol goes to muscle, then it's going to increase protein breakdown. And if cortisol goes to adipose tissue, then it increases in lipolysis. Okay, some other hormones that are not related to the hypothalamus is we have the thyroid, specifically the parafollicular cells that are found around the follicles. Okay, so the thyroid has some follicles, and then around them are the parafollicular or parafollicle cells, and they release calcitonin, which is the hormone that communicates with bone. And what it does is it increases calcium storage in bone, and thus helps you decrease blood calcium levels. Okay, so this next thing I'm going to say gets a little fancy. We're going to use some big words here. So hypocalcemia versus hypercalcemia. Okay, so hypo is below. There's your calcium, and emia means blood. And then you have hyper, which is too much of calcium, and emia, which is blood. So hypercalcemia means too much calcium in the blood, and hypocalcemia means not enough calcium in the blood. All right, so if a person is currently experiencing hypercalcemia because of diet, you had a bunch of dairy, you took a calcium supplement, whatever, you're going to have an increase in blood calcium levels. So then what the body does is it releases calcitonin, which will then put the calcium in bone. Okay, now things that will help with this process is adequate levels of vitamin D, vitamin D3, and exercise. Okay, what exercise does is it's the pull against gravity. Muscle tapers into a tendon and is connected to bone. So essentially, muscle is connected to bone. And pulling on bone, or the pull against gravity, especially with weights or weight training, is actually really healthy for bone. It builds strong bone. Now, exercise alone isn't enough. You also need the diet part. Okay, so adequate diet, so adequate levels of calcium and vitamin D will also help with this whole bone building process. Okay, calcium storage in bone. Okay, the opposite of calcitonin. By the way, you had hypercalcemia. Once calcitonin is activated, you're going to bring down those blood calcium levels back to normal. Okay, so you went from hyper, too much calcium in blood, down to now normal levels. And that's one of the jobs of calcitonin. All right, the opposite of calcitonin is the parathyroid hormone. All right, so the parathyroid gland releases parathyroid hormone. And if that goes to bone, then you're going to remove calcium from bone. And what this will do is increase blood calcium levels. Now, in order for this to have happened, you would have had hypocalcemia. Okay, so not enough calcium in blood, and your body is basically assuming, well, I've got low calcium levels. That's not good. Doesn't look like you're going to be eating calcium anytime soon. So fine, I'll go to bone to pull calcium out of bone. Calcium is a great storage site for, or bone is a great storage site for calcium. So you're going to activate osteoclasts. Okay, and the job of osteo is bone, and the job of a clast is to break down bone. So when parathyroid hormone is released, you're going to activate osteoclast, which is going to remove calcium from bone, which will bring up blood calcium levels. Okay, if parathyroid hormone goes to the kidneys, you're going to help convert or activate vitamin D3. All right, so the quick version of vitamin D synthesis is sunlight will hit your skin, which then activates your parathyroid glands to release parathyroid hormone. The kidneys are involved, and it's a really fancy biochemical reaction that our body goes through to ultimately produce vitamin D. Okay, so when we get that from the sun, the parathyroid hormone is involved, the kidneys are involved, and that will help convert and activate it into vitamin D3. All right, next we're going to look at the posterior pituitary, and that only releases two hormones. Okay, the posterior pituitary releases ADH, also known as vasopressin, Okay, ADH stands for antidiuretic hormone. Okay, now write this down. In the presence of ADH, you keep fluid. Okay, in the presence of ADH, you keep fluid. Okay, think about the statement, antidiuretic hormone. All right, let's look at it the other way. What is a diuretic? A diuretic will make you lose fluid. So an antidiuretic will help you keep fluid. Okay, so make sure you wrote that down and understand the difference. In the presence of ADH, you keep fluid. Okay, so antidiuretic hormone is released from the posterior pituitary. If it goes to the kidneys, you will keep retain fluid. Okay, now by fluid, we mean water. Okay, now, on a side note, obviously we have to urinate, and so that is a kidney function, and water and fluid goes to the kidney, and a little bit of fluid is removed from your body and stored into the urinary bladder along with all of the waste, okay, the metabolic waste. Now, we'll talk about kidney and metabolic waste down the road, okay, but for now, once the fluid is stored in the urinary bladder, at some point you have to pee, and that's our body's way of getting rid of byproducts. Okay, so now likewise, if ADH isn't working, so then your body's just in basically diuretic mode, which means you're going to be losing too much fluid. All right, now that would be a story for another time. So going back to normal structure and function, the kidneys are going to help you retain fluid. Okay, vasopressin. Now the word vasopressin. Okay, so vaso is blood vessel or the arteries, and pressin is literally pressing down on something. All right, so if you look down the barrel of a tube, and the tube in this case is our arteries, so we have on a side view, okay, we'll say an artery looks like that, so there's the tube, and we're going to look down the barrel of the tube, which means we're going to look at it like this. So we're going to call this one vasodilation. All right, so it's nice and open. Vasodilation. And then what happens is these blood vessels can constrict. So that's vasoconstriction. So my shorthand is vaso-C and vaso-D, and they stand for vasodilation and vasoconstriction. All right, so vasopressin will cause the blood vessels to vasoconstrict. And when that happens, okay, when you have a vasopressin causes vasoconstriction, this increases peripheral resistance. And what this means is it will increase blood pressure. Okay, why? All right, this next thing I'm going to go over, please pay attention to this. All right, the pump in our body is our heart. Okay, the heart or the pump is hooked up to these tubes. Okay, so this is going to be scenario 1, and here is scenario 2. So we have the heart, which is a pump, and this particular blood vessel I'm going to make skinny on purpose. All right, so this one is vasodilated, and this one is vasoconstricted. Now, if you have a pump, and the pump has to squeeze fluid through the tube, okay, which is our blood. Which one is easier to push fluid through? A tube that's nice and open or a tube that is nice and skinny? Okay, well, the answer is it's easier to push fluid through vasodilation, and it's harder to push fluid through a really skinny tube. Okay, so the pump has to work harder. So if you are in vasoconstriction, then you're going to increase blood pressure. So the heart has to work harder to push fluid through a skinny tube. And the fancy way of saying that is it increases peripheral resistance. Now, what is your periphery? Well, it's your entire body, your arms, your legs, all the way down to your hands and feet and everything in between. That's the entire periphery of the body, peripheral resistance. If that person who was in vasoconstriction experiences vasodilation, then the blood pressure will come down because it's easier to push fluid through big open tubes. Okay, so that's the job of vasopressin. All right, so it's the same hormone, but they change the name depending on the organ or tissue that it communicates with. So when ADH goes to the kidneys, you keep or retain fluid. If vasopressin, so the same ingredient, the same hormone, goes to blood vessels, it causes vasoconstriction, vasopressin. Okay, like you're pressing down on the tube. All right, the second hormone that the posterior pituitary releases is oxytocin. Okay. So if oxytocin goes to the breast tissue, then it's going to help with milk letdown. And if oxytocin goes to the uterus, and this is going to be during pregnancy, then you're going to get contraction to help push baby out. So when the head of the baby presses against the wall of the uterus, it sends a feedback mechanism to the posterior pituitary to release more oxytocin to make the uterus contract harder to help push baby out. Okay, side note with oxytocin, it's also known as the cuddle hormone, or the bonding hormone. Okay, and so both men and women have oxytocin. Women just have more of it, especially during pregnancy. And it really kicks into gear after delivery. Okay, so sometimes these moms-to-be aren't quite sure about this whole baby thing because it's their first one, and they're like, I don't know if I, feel this connection and whatever. But something magical happens after birth, and that bonding hormone and that motherhood stuff just kicks in. And it's enhanced when baby is then placed on mother's chest. So now we're skin to skin. And then also with the feeding. Okay, so nipple stimulation or breastfeeding. So nipple stimulation via breastfeeding also helps release oxytocin, which will then also help seal up what's called the second birth, where the placenta was on the uterus. Okay, so the first birth is baby coming out. Second birth is placenta coming out. Now, placenta was attached to the wall of the uterus. So you can kind of use the pulling off a scab analogy. Okay, so if you pull a scab off, you now have an open wound and you can bleed. So where the placenta was on the uterus, now that the placenta has been essentially pulled off, kind of like you pull off a scab, now there's a wound site, okay, and there's bleeding. Nipple stimulation releases oxytocin, which helps seal up that wound quicker. So it's really important after delivery to try to do nipple stimulation / breastfeeding as soon as possible.